Chapter 2, Communication, Computer Essentials, and Documentation. Again, this is the chapter objectives that will be covered in this PowerPoint chapter. Verbal skills. Nonverbal skills is our second blank. Active listening and written language. These are things that we might see in our patient, both the verbal and nonverbal, to let us know what's going on with our patient during the blood draw, after the blood draw, and even prior to. Active listening is really essential in our field. This is where we get a lot of our detail from our patient. Also, too, with active listening, we're going to also pay attention to patient's personal preference of what arm they want to be drawn from, and also any history we might need to know as well. Figure 2/1 communication loop gives the message verbal, nonverbal to the receiver, who encodes it, then gives feedback, decodes it again, and then the sender receives it. This can be an issue when we look at the centerpiece, the age of our patient, language spoken, sensory impairments, jargon, medical jargon, could potentially mess up the message as we go, and we will have an activity on this in class. Figure 2/2, degree of communication effectiveness. Numerical data being the lowest, highest is being our face-to-face conversation, but a lot of our information nowadays, even to know it's considered low, is in this written documentation, email, so being aware of appropriate communication during our email processes as well. With whom do healthcare workers communicate? Consider the stakeholders identified in Chapter 1, so our patients, other healthcare workers, peers, supervisors. Consider generational differences, so how we treat our pediatric teens is different than our elderly. And consider cultural issues and health literacy. Can the patient understand what we're communicating? Also, too, cultural differences that might impact the patient agreeing to certain procedures. Consider gender differences. Be knowledgeable about strategies for all groups. So in this circumstance, the medical assistant is interacting with the family. She's at their level, and you could see the nonverbal expressions on their face. Communicating with patients and the team members, healthcare team meeting. We'll review this in class, but look at the different nonverbal facial expressions. What does that tell us about the situation or the communication being addressed? Verbal communication, this is show empathy for waking up patients, disturbing them, or interrupting meals. We do wake patients up at 5 a.m. to draw their blood, so have empathy. Show respect for privacy for their condition or for their family members. Build trust, maintain confidentiality, and explain procedure, and be truthful. And establish a rapport, common courtesy, show interest. Building trust with our patients is definitely essential when we work with children. There's a level of trust where we have to kind of show them a level of respect, but also make sure that they understand the procedure as well. On occasion, a healthcare worker may need to sit down near the patient to spend extra time explaining the procedure or to answer questions. The healthcare worker is actively listening to patients' concerns in a compassionate manner. Verbal communication, again, listen actively, face the patient. Maintain non-authoritative posture, so don't cross your arms. Lean towards the patient, establish eye contact, and listen intently. Provide specific feedback if need be about their behavior or procedure. We're going to avoid sending mixed messages to patients, so practice using a calm, soothing, confident tone of voice. Use simple, straightforward vocabulary. Use proper pronunciation and grammar. We're going to avoid medical, complex jargon or medical terminology. We need to consider communication across the generations, and I will have you review this in your textbook and on these next slides. We will be discussing this in class as well. Languages other than English. Patients who do not speak English can understand some basic nonverbal communication. Communicate the same essential information prior to the procedure. We have a lot of procedural brochures that for patients of different languages. We also seek assistance from a supervisor, translator, family member, or translate service or physician. Be sure that the patient is well informed. how to access translation services, healthcare workers who speak other languages, audio tapes, written instruction in patient's language, language services available by phone or by internet now. We even have on our on our phone, we have Google Translator, which could help. Does not work very well for medical terminology, but can get basic concepts across. Hearing impairments. All patients, regardless of impairments, must understand healthcare procedures before beginning. If the patient does not hear well, do not shout. Simply speak slightly louder and slower while facing the patient and check for better hearing on the other side of the ear. Hearing impairment, you're going to select the best options of communication, and I will have you review this slide on your own. We're going to reduce external noise. To begin, smile, establish eye contact. We're going to introduce yourself and state reason for the visit. A blind patient will not see you smile, but appreciate knowing who you are and why you're there. Be aware of verbal and nonverbal cues from your patient as well. The patient does not respond, he or she may not have heard or understood what was said. So if the patient turns the head to one side, he or she may hear better on that side, so move to that side. And we're going to face the patient, speak slowly, and do not shout. Again, I'm going to have you review this slide on your own. Please be aware with our patients that are deaf that they might have directions using actions as well as words. So they might actually have you write out something. The other thing, ask the patient if there's a step you would like me to repeat before we begin. A lot of them have some type of tablet or writing utensils because they can't hear that they can write on to communicate with you. Our blank is do not proceed until you assure the patient understands and is aware of what's going on. Patients who have visual impairments, we're going to speak directly to the patient. Do not raise your voice or speak to the companion if there is one. If the workspaces are small, caution patients about objects that may be in their way. We do not grab the patient's arm to steer him or her. Instead, offer your arm to let the patient decide if he or she needs assistance. Describe steps or turns as you approach them. If you need to move furniture or medication out of the way prior to procedure, be sure to put things back where they were. Let the patient know if he or she is in the room, if there are any others present, so that they're aware of where their location is. I will have you review this slide on your own, as well as the next slide. Pace, tone, and volume of voice. Our pace is determined by rate of speed and urgency. I will discuss this more in class along with tone and volume to give you some face-to-face representation of this. We need to be aware of pitch of voice, range from loud shouts to soft whispers. Sarcasm, done by changing tone of voice. Emergency situations, usually high-pitched, rapidly paced voice, and practice using a calm, soothing, moderate-paced voice when we are speaking with patients. Nonverbal communication aids in communication, makes patient interactions more pleasant. Face-to-face positioning, relaxed hands, arms, and shoulders. Smiling, eye contact, and eye level and zone of comfort. And we will be reviewing this in class as well. This gives some examples of positive and negative body language and some examples as well. Zone of comfort for interpersonal space. So intimate space, direct contact up to 18 inches. This is phlebotomy. Close relationships and healthcare workers who bathe, feed, dress, and perform venipunctures. We are about 18 inches or less away from our patients. Personal space, 18 inches to 4 feet. Interactions among friends, many other patient encounters. Social space, 4 to 12 feet. Interactions of everyday life, and 12 feet or more would be lectures and speeches. So we are in their intimate space. Unfortunately, we are waking them up early in the morning, and we are in their what we call personal bubble. Please review this slide on your own and consider your own culture when we look at values, beliefs, traditions, and practices. We will be covering the blanks of this slide in class. The healthcare worker is discussing a procedure with the patient and her family. Negative body language, wandering eyes, yawning, stretching, breathing pattern, crossed arms or wrinkled foreheads, frequent glances at the clock, or some negative body language that we need to be aware of. Ignoring, disinterested, aggressive, and defiant. We will be covering these examples in class as well. Active listening, I will have you review this slide on your own. Written communication, online and handwritten, I will have you review this slide on your own as well. Family visitors and significant others. If several visitors are in the patient's room, they may be asked to step out while the venipuncture is performed. Be sensitive to the patient's privacy and confidentiality in the presence of visitors. Do not reveal test results unless appropriate to do so. Family visitors and significant others. Children must be attended by an adult at all times. Physicians, priests, or chaplains have the right to visit privately with patients, offer to come back later if need be. Family visitors and significant others. If the procedure is timed or stat, which needs to be drawn within 1 hour, apologize for the interruption, explain the nature of the request, and ask permission to collect the specimen. Families or visitors should not be permitted in the clinical laboratory, just so you are aware, except for parents of pediatric patients. When meeting the patient for the first time, I'm going to have you review this slide on your own. We will be covering this in class. Correct patient identification is extremely important, must be done right every time. Mistakes can be deadly. So it's essential we verify the patient's first and last name, date of birth. Sometimes too we ask for their middle initial. We might compare that versus their medical record number as well. After greeting and informing patient of intentions, carefully check forms of ID. The Joint Commission recommends 2 unique patient identifiers to identify patients, such as armband, driver's license, with verbal communication from the patient. Ask, please state and spell your name. Do not use patient's hospital room number, which is our blank. Identification will be discussed later in detail. So we're going to ask, compare, and then verify and validate. For patient identification by 3-way match, we're going to check the test requisition and labels, check the hospital identification armband, and then we're going to also ask for the patient's verbal identification. If the patient does not have an armband, the identification can be made by a unit nurse who knows the patient well. Document the name of the nurse who made the identification on the requisition. Communication in the ambulatory setting. Identification must be well documented, especially for homebound patients, mobile vans, and other off-site locations. Identity can include demographic data such as patient's ID number, date of birth, address, or checking driver's license. We're going to confirm information by the patient prior to blood collection. Computerization of the clinical laboratory. Manual systems require human intervention. Semi-automated systems, little human intervention is required. And automated, little or no human intervention is required. Know which systems are used in your healthcare facilities, and we will be providing examples in class. And this is just some of the components of the computer system. The laboratory requisition and label, I will have you review this on your own. I will be covering this in detail in class. There's different types of technology, semi-automated and automated. We have barcodes, RFID, and armband options. This gives you the barcode option, where we could scan a specimen in. The example identification wristband on a patient. Note that the wristband has 2 types of barcodes. This concludes Chapter 2, Part 1. Please review Chapter 2, Part 2 to finish this slideshow.